This explainer is based on gaze stabilization training, principles and prescription, mechanisms, exercise library, and outcome measurement, published by Australian Dizziness Clinics. Welcome back to part 3 of our Clinical Explainer series. Today, we're taking the foundational neurophysiology we tackled earlier and turning into a concrete, clinic-ready prescription. We're basically stepping off the chalkboard and right onto the clinic floor. If you're a physio or a vestibular specialist looking to truly master exactly how to prescribe, dose, and progress these vital exercises, you are in the right place.
Here's our quick roadmap for today. We'll start with the gaze stabilization gap, then move into core drills and standard dose. After that, progression and symptom rules, and finally, key takeaways and next steps.
All right, section 1, the gaze stabilization gap. So let's talk about a really frustrating reality. You know the one, handing out those generic gaze stabilization printouts. To paint a picture of this gap, let's look at a tale of two patients. Imagine patient A and patient B. They both walk into your clinic with unilateral vestibular hypofunction. You hand them the exact same printout of gaze drills. 6 weeks roll by. Patient A, they're back to running, vision is crystal clear. But patient B reports absolutely zero improvement, nothing, even though they had the exact same piece of paper. It's incredibly frustrating, right? But it actually points to a massive truth in vestibular rehab.
Which brings us to the big question. Why on earth do identical exercise lists produce such wildly different clinical outcomes? Well, the answer is that generic lists simply don't drive plasticity. The magic isn't in the list itself, it's all about the strict application of dosing, progression, and symptom provocation rules. See, if the dose doesn't match the deficit, and if it doesn't provoke what we call retinal slip, the brain just doesn't get an error signal. And no error signal sent to the cerebellar flocculus means absolutely zero adaptation. Patient B didn't fail because the exercises were wrong, they failed because the parameters weren't dialed in to force their brain to adapt.
Section 2, core drills and standard dose. Now let's dive into the actual exercise library itself. We want to see exactly how to dose these drills right from session 1, so every single patient looks like patient A. The entire gaze stabilization exercise library can be beautifully categorized into 4 progressive families. On the foundational side, we've got adaptation exercises, like VORX1 and VORX2, which we use when the patient has some residual vestibular function. As we progress, we layer in variants, things like near-far switching and reading text while turning the head. And finally, we push into complex functional integration with busy backgrounds and standing or walking layers. It's basically a map that takes your patient from sitting quietly in a room all the way back to navigating a chaotic supermarket aisle.
Okay, let's break down this layering strategy step by step. Step 1 is VORX1. The patient fixates on a stationary target and oscillates their head at about 1 to 2 Hz, moving through roughly 20 degrees of amplitude in either yaw, that's left-right, or pitch, which is up-down. Once they absolutely master that, we step it up to step 2, VORX2. Now the target moves in the opposite direction to the head. Just imagine the energy demand there. It literally doubles the demand on the vestibulo-ocular reflex and massively spikes that retinal slip signal. Step 3 brings in near-far switching, where they bounce their fixation between 2 targets at different depths during the head turn. And for step 4, we layer in standing and walking, tying in postural control so they're adapting their entire balance system, not just their eyes.
Let's look closely at the precise, evidence-based starting doses for these drills. For your X1 and X2 drills, you're starting at 1 to 2 minutes per axis, 3 to 5 times a day. Did you catch that frequency? 3 to 5 times a day. Why? Because spaced practice beats massed practice every single time. Doing a 15-minute chunk all at once on a Sunday just isn't going to cut it. The brain needs repeated, spaced-out error signals to actually drive neuroplasticity. The sweet spot is a total practice volume of 12 to 20 minutes a day across all access. Pushing past 30 minutes a day doesn't get you better outcomes. Honestly, it just ruins patient compliance.
I really want to highlight a crucial clinical pearl straight from the source material. If the patient reports the target stays perfectly clear at every velocity, the dose is too low. I literally cannot emphasize this enough. If that target is perfectly sharp, you have no retinal slip. And without retinal slip, no error signal to the cerebellum, which means zero adaptation. You actually need your patient to crank up their head velocity right to the point where the target just starts to blur. That little bit of blur, that is your therapeutic sweet spot.
Moving on to section 3, progression and symptom rules. So getting the dose right is a great start, but the real expertise is knowing how to progress safely without completely overwhelming your patient or losing their trust. Let's anchor on our primary heuristic here, the symptom rule. When you prescribe these exercises, you have to educate the patient that mild to moderate dizziness during and right after the session isn't just expected, it's strictly required. Tell them if they aren't a little dizzy, they're kind of wasting their time. That dizziness proves active retinal slip processing is happening.
But here's the safety valve. Those symptoms need to settle down within 15 to 20 minutes. If they get mild symptoms that settle fast, you can assure them they are exactly in the right therapeutic zone. Now, how do we progress? If a patient plateaus, meaning their clinical scores aren't improving after about 4 weeks, the answer is definitely not just do more of the same. You don't just tack on more minutes. Instead, you escalate one specific lagging dimension. You could crank the head velocity up to 3 or 4 hertz. You might weave in vertical and diagonal axes. You can throw in busy backgrounds, having them do the drill staring at a patterned wall or watching moving traffic. You could layer in postural challenges like standing on foam or tandem walking. Or try increasing the cognitive load by making them count backwards during the drill. Just pick one dimension, turn the dial up, and force that brain to adapt all over again.
But what happens if we push a little too hard? The source gives us a crystal clear rule. Severe symptoms lasting past 30 minutes means back off, not stop entirely. If your patient gets hit with severe nausea, vegetative symptoms, or dizziness that lasts beyond an hour, you escalated the dose way too fast. But do not let them abandon the program. Instead, instruct them to dial back the head velocity or the amplitude by about 20% and slowly reintroduce it. Look, underdosing is definitely a problem, but overdosing that leads a patient to drop out, that's an absolute tragedy. You've got to keep them in the game.
Section 4. Key takeaways and next steps.
Let's wrap this explainer up with the high-yield clinical pearls you can use with your very next patient. Number 1, start with X1, completely master X1, and only then introduce X2. Skipping that X1 mastery is the #1 reason for symptom flare-ups and program dropouts. Number 2, systematically layer those progressions. Go from near-far switching to busy backgrounds, then standing, and finally walking. Number 3, respect the dose. That's 1 to 2 minutes per axis, 3 to 5 times a day. Space practice is totally non-negotiable. And lastly, the symptom rule. Mild provocation that settles in 15 to 20 minutes means you've hit the neuroplastic sweet spot. That is exactly how you transform a basic checklist into a powerful adaptation-driving program.
So, what's our next step? In part 4 of this series, we're going to close the loop on tracking these exact outcomes. We'll dive into objective measurements like dynamic visual acuity, the functional head impulse test, and the dizziness handicap inventory. We're going to explore clinically meaningful changes, what specifically triggers a plateau, and then wrap up the whole series. You definitely won't want to miss learning how to objectively prove that your training is actually working. To grab the full literature review and clinical algorithms we talked about today, head over to AustralianDizzinessClinics.com. If you found this explainer helpful for your practice, please make sure to subscribe and rate. So, before your very next patient walks through that door, I want to leave you with this thought. Are you just handing out generic exercise lists, or are you actually driving neuroplasticity? Catch you next time.